invitation. He was very smart. He said, Dr. Bartlett is coming. Are you interested in coming to this meeting? How could I say no? If he's going, perfect. So when and where? So here we are, and again, thank you. I'm going to do a rapid fire session on, actually we're putting two topics together, heart transplant, ECMO use in heart transplant and lung transplant in one talk. So we're going to go pretty rapidly, and I'm going to try to give you an overview of these, the interesting changes that have occurred, especially more recently on heart transplant, in which we may see an important change based on the changes on the allocation. I have no disclosures, by the way. On the topic, again, update on ECMO as a bridge to heart and lung transplantation, both. As you all know, we're getting close to the 50th anniversary of ECMO use. The first publication, 1971, with that patient with lung contusion, and a lot has happened since then. The use of the membrane oxygenator, now the polymethylbenzene oxygenators, has really made an incredible change in ECMO support. And how to forget the contribution of Dr. Bartlett with initially the pediatric population. But again, things have changed very rapidly. We're seeing more and more use of ECMO. The number, the graphic speaks by itself here, close to 5,000 ECMOs recorded on ELSO performed every year in the US. This has happened in the lung field, in the cardiac field in the adult. We see an increasing number of ECMO centers, more than 200 centers in the US. Again, close to 5,000 cases done every year for lung and heart disease in the adult and the pediatric population. In yellow here is the US. As our previous speakers mentioned, there's been a change in the indication of ECMO. Now the most frequent indication is lung and heart disease. In the adult, the pediatric indication is decreasing a little bit, but mostly we're seeing a rapid increase in lung failure, ARDS, and lung transplant, mostly bridge to transplant and post-lung transplant, but also in the cardiac population, in cardiogenic shock and ECPR. As you have seen, the outcomes have improved, and that's what we're all here talking about it and learning about it. As we have learned, we have also been able to improve the outcomes. And we see today in this very, very sick population survival that goes close to 60 to 70% in patients with lung disease and lung failure, especially ERDS, close to 80% in lung transplantation. And in cardiogenic shock, we're getting close to the 50, 60% in specialized centers. So we've made very important improvements, and there's been a lot of contribution from multiple centers in this field. There's no doubt that it is the technology that has changed, especially with the last 10 years, not just with the miniaturization of the circuits, the coated circuits, the coated tubing that had made the ECMO management much easier, the fact that we're avoiding the bridges on the ECMO, preventing a clot formation, but also evidently the oxygenator, the polymethylbenzene fibers have made a huge contribution, now running ECMOs for 2-3 weeks sometimes without changing the oxygenator. This has decreased hemolysis, shear, stress, improved gas exchange, etc., increasing the durability of the devices. Also, the cannulas have improved, not just the dual lumen catheters popularized about 10 years ago by the Maryland group, in which we had the fortune to publish the first paper with so far excellent results. We now have a new version for a right ventricular support, so-called a Protect Duo cannula, but also the arterial cannulas and the venous cannulas have improved. They're smaller. We get better flows with them, so we can support patients with smaller size cannulas between 15 French or 20 French. So this really has made a huge difference in the way we do ECMO today, and really created what I consider the revolution. I was fortunate enough to be finishing my training in Pittsburgh in early 2000. And when we saw this new technology coming on board, and I was fortunate enough to be there and appreciated the importance, and we initiated this use of these technologies in bridge to lung transplant, post-cardiotomy shock with increasing numbers. Today in our institution, I moved to University of Pennsylvania. We perform about 200 ECMOs a year with similar outcomes that you saw on the slide. And as we do, many other institutions that also do in larger numbers. So it's really an important revolution from what we used to see 15 years ago, to what we're trying to do today. Not every patient evidently gets to this point, but if you learn how to organize your team, to coordinate your system well enough to provide this type of support, you see patients like this walking on ECMO for a month or two without major problems. Now, let's go now to the specific topic of heart transplant and how things have changed and will continue to change with the ECMO use in heart transplantation. As the number of ECMO has increased, also the number of short-term support devices, especially percutaneous, have increased very rapidly over the last few years to support patients in cardiogenic shock. Unfortunately, the data to support these devices, especially if we're talking about the Impellas and the tandem hearts, is being not very stimulating in terms of improving outcomes compared to the intra-aortic balloon. You can see that on the IMPRESS trial, which the Impella CP was compared to the intra-aortic balloon in a group of patients with MI showing no difference in survival. Same thing happened in the shock trial with the use of intra-aortic balloon versus medical treatment in patients with cardiogenic shock post-MI with no improvement in survival. So these were two randomized trials, unfortunately not showing any benefit of these devices versus the standard treatment. And if you consider the versatility of ECMO, that is so easy to place bedside anywhere, doing on the street sometimes in Paris, the reality that this is the reason, the versatility and the ability to support the right ventricle and the provide oxygenation that has kept ECMO at a very high volume and level, basically in all the patients, all the centers supporting patients with cardiogenic shock, despite of other devices being available. And I don't see that changing anytime soon. Now, if you look at the data on the use of ECMO in cardiogenic shock, it's not extremely consistent. We have a lot of reports of use of ECMO. There are a single center series or some meta-analysis. This is one of them. But if you look at the studies in general, they combine a different group of populations, patients with MI, post-cardiotomy shock, post-surgery, etc. Interestingly, some of these studies also include the second destination. They include in the outcomes when a patient was transferred to a more durable device, now the continuous flow pumps in the form of a hardware or a HeartMate 2 or HeartMate 3, but also there's a few theories showing the outcomes of ECMO use as a bridge to heart transplant. As you see, very few single digits in very a few of these papers. But again, these are all cohort studies. There is no randomized study done on ECMO on the cardiac world. There is one study done in ARDS, as you know well. But if you look at these cohort studies, in general, we can say that survival goes anywhere between 30 and 60%. Now we're getting close to the 70% in some of these series. About 5 to 35% of these patients have gone to a durable device because the heart has not been able to recover or the patient has died. And in about 4 to 20% of these series, patients have gone, and in general, this has happened in Europe as they don't have a LVAD technology available as we have it here. About 4 to 21% of these series have gone from ECMO to a heart transplant. So again, in general, this has been very carefully selected a group of patients undergoing heart transplant from ECMO. Most of the time we have concentrated now in the US to transfer this patient from ECMO to a continuous flow pump. I'm not going to go in detail of the outcomes because of time, but that's been what has happened over the last 10 years since the first publication by Pagani with the concept of bridge-to-bridge from ECMO to a continuous flow pump. And the reason why we have concentrated on LVAD is based on other experiences. This is a pediatric experience showing that when you consider the different type of support to a heart transplant, ECMO has significantly worse outcomes compared to LVAD, even in those cases that we do ECMO as a bridge to an LVAD. So ECMO directly heart transplant in the pediatric population in the US was associated with poor outcomes. And we knew that. There were sick patients. So for that reason, we kept a heart transplant as a second option in very selected group of patients, especially myocarditis, some patients with restricted cardiomyopathy that were not good VAD candidates. So very selected. And we kept this for many years until recently, there was a subcommittee in OPTN that got concerned about the increasing the number of 1A status in heart transplant wait lists, mostly due to the rapid increase in the LVAD population. They were also very concerned about the fact that there was a rapid increase in the number of exceptions requested to the committees. And that was really putting an important burden on this group. And they did an analysis of patients in between 2010 and 11 using a stroma statistical method. And basically they show something interesting, that despite of the low numbers of ECMO patients that were bridged to heart transplant and the high mortality on the wait list and the high mortality post-transplant, there was a significant benefit from this technique of ECMO, bridge to heart transplant, done in a selected group of patients using this statistical method. Actually, it was better in terms of benefit compared to that. The mortality decrease was more significant in the ECMO group. So they thought, well, if this is done in a controlled fashion, actually could bring benefit. And if you see here, the same analysis, this is the survival of ECMO patients versus other devices. ECMO had a 77% survival at 1 year, so much worse than the other devices, but still was providing a benefit to the population based on the statistical analysis. And based on this data, now they propose changes in the allocation system and that they're approved and are probably going to start running during the summer, that ECMO will be considered now as a status 1 for 14 days versus LVAD that is going to be considered as a status 3 for 30 days. And remember that today, LVADs have 30 days granted of a status 1A for a transplantation. So this is really, this may really have a tremendous impact on the way we do transplant today. Now, we look at the data to support this. The reality, there is not much around. And the first paper available on a larger series with 15 cases was this series from Taiwan. Again, 15 patients that were transplanted directly from ECMO with a survival of 64% at discharge versus 50% of the VAD population. They concluding based on the study that the age and pre-ECMO CPR was considered a risk factor for mortality in this patient population. This is a series from France. Again, we're doing this more in Europe because of the lack of continuous flow pumps or the complexity of getting those in some of these areas. And in 80 patients that they consider an urgent status, they were able to transplant about with a transplant about 65%, and about 28% of these patients were died on the wait list or were delisted. When they analyze the survival, the survival of the ECMO group overall, including those actually that did not get to transplant, was significantly higher than the patients that were not supported on ECMO, 52% at 1 year versus 75% at 1 year. Now, if the patient were able to get to transplant, the survival was not so different. There was a 10-point difference in survival between the ECMO group and the non-ECMO group. And they concluded that transplantation provided a survival benefit in listed patients on VE ECMO, even though there was a higher mortality after a transplant, and for that reason, in Europe, VE ECMO should be considered. The strongest data we have here in the US is this recent paper just published a few weeks ago, the use of ECMO as direct bridge to heart transplantation analysis of UNOS, 107 patients between 2003 and 2016, compared to continuous flow LVAD patients that underwent heart transplantation. Patients were sicker. Almost 40% of these patients were intubated compared to less than 1% of the LVAD population. There were more congenital patients in this ECMO group as they're not great VAD candidates. Interestingly, only about 65% of these patients were not listed at the time of ECMO implantation, and they were rapidly evaluated and listed. But again, you see a significant difference in survival. ECMO mortality around 35%, for the overall group versus 18% for the LVAD population at 3 years. Now, they did a match pair between the two groups of 82 patients, still that difference persistent in this match cohort. We learned a few things from this paper, that patients on ECMO were a little more debilitated after transplant, requiring total assistance before the propensity match in 50% versus 12% on the ECMO, on the VAD patients. We also learned that the patients on ECMO had more CVA, 9% versus 3%, and more renal failure. Now, this difference was not present in the match cohort. Another thing that we learned from that study is that patients on ECMO died more significantly, different to the VAD group, more from multi-organic failure, showing how sick these patients were before transplant. Another important message of this study is the importance of the liver function at the time of transplant, and they show us that patients with high MELD score, greater than 17, had a significantly higher mortality at the time of transplant. This is probably the most important publication in the US with the use of ECMO as a bridge to transplant. This is our experience at Penn. We had 7 patients transplanted directly to heart transplant from ECMO, as they were very well selected. Young patients with myocarditis, they were already listed, or we were able to list them within a few days. We had 100% survival. But again, very well selected population, better than continuous flow pump, but again, in a very well selected group. There have been some other recent presentations at the ISHLT and the SDS recently, again showing this is UNOS analysis from the Houston group. This is again another study from France showing no difference in survival in a well-selected group of patients supported on ECMO with cardiogenic shock as a bridge to transplant. So the reality is that we don't have a really good picture of what's going to happen and what the outcomes are going to be. But there are still questions that we need to answer. Some of them include, who should we support on ECMO versus VAD? How do we support these patients? What is the best strategy? What is the timing of listing? When do we transition to other devices? These questions have not been answered yet. In general, we're using patients, supporting on ECMO patients with myocarditis, because some of them even may have the chance of recovery. Retransplants, as I have biventricular failure, they're well supported on ECMO. Poor LVAD candidates, patients with restrictive cardiomyopathy, congenital disease. Eventually, young patients may be considered if we want to avoid them, 2 years on an LVAD, and we may be using more this in the younger population. But it's still to be determined. We don't know what is going to be the final indication for this ECMO group. The way to do it, the only thing, we know the way we cannulate ECMO, peripheral, axillary cannulation, central cannulation. The only thing I can say is that you need to use the most stable platform possible to keep these patients for 2 weeks without problems. And what we need to avoid is vascular complications. We need to avoid lung complications and infection. And it's important, if we're going to consider the femoral cannulation, to use distal perfusion. It's been well documented now that you decrease from 15% to 5% or 6% the rate of vascular complications requiring surgery when you do this. We do it routinely in 100% of our patients. The axial cannulation can be done also with a cannula and the IJ in order to mobilize patients, but we know that the axial cannulation has some complexity, increasing bleeding compared to femoral cannulation. You sometimes need to go back to the OR multiple times. We have improved the techniques, but it's still not perfect. We use an 8mm graft, although allows mobility, and you can seat patients and eventually mobilize them. The femoral, even though it's a good strategy, limits mobility, has potential risk of vascular complications, etc. Also beware of hyperperfusion of the upper extremity. You need to basically cinch and decrease the size of the distal axillary of the axillary artery to try to decrease the perfusion about 50% to avoid this problem, hyperperfusion of the upper extremity. Other important things that have not been defined is how do we decrease the risk of lung injury, strokes, and we know that especially femoral cannulation can increase the left ventricular volume overload, especially when we increase the flows, and you see a right displacement of the pressure volume curves when we do high flows on peripheral VA ECMO, especially complex when you have some degree of AI. And this may have significant clinical implications. One is when you don't unload the ventricle, you can create clots and eventually increase the rate of stroke. You can increase the risk of aortic root thrombus, CVA, and pulmonary hemorrhage. So really we need to put a lot of effort in trying to minimize these complications. There are different alternatives that we're not going to discuss today, how to prevent this. Percutaneously, today we're using more Impella. A balloon doesn't do much, but there are also some other open techniques that are very useful, and you need to be very proactive in doing them. I don't think we should forget the central cannulation, because when it's well done, I can tell you that it's a very stable platform. We use grafts today. We have ways to do it better, and we have now patients walking, and I don't know if we can make this work. No, but you see now these two patients walking. This was a patient cannulated for a month on RA-LA ECMO. This one was a central RVAD, cannulated for 2 months walking in the hospital. So central cannulation doesn't mean that you cannot mobilize patients. You need to do it right. Now, some of the data regarding the unloading, how to unload the ventricle better. There is some recent data. This is a study from Papalardo comparing Impella with ECMO versus ECMO alone. And what it shows us that basically you can decrease the mortality when you unload the ventricle. This was a prospective match cohort study. It was not randomized. But they show improvement in survival, improvement of weaning of ECMO, at cost of higher renal failure, probably because of the hemolysis. So again, we don't have the final answer on this, but eventually, if you get in trouble and your ventricle gets extended on ECMO, you may need to be more proactive unloading this ventricle. We're doing a randomized study in my center. I'm the PI of the so-called reverse trial, in which we're going to try to answer this question in a randomized fashion. But you can also do this surgically, cannulating directly the apex. This is a study from Columbia University showing that this apical cannulation is very similar in terms of decreasing pulmonary pressure compared to the use of Impella. I'm not going to spend too much time, but again, there are different ways to do this safely today. But another concept that is very important is the fact that you need to try to avoid lung infections. And the best way to do that is to avoid intubation, try to get patients extubated. This is a series from Hanover in patients with cardiogenic shock showing good survival in very sick patients, 23 with extubation. And I think it's very important that we try in those patients that are stable without other complications to try to get them extubated to prevent that problem, especially we're waiting for heart transplant. And here we have a case in which we waited 6 days on ECMO, extubated, was placed actually before the patient arrested in a preemptive fashion, and we were able to get this patient discharged 8 days after transplant. So again, good strategy. But other things that are important in consideration when we do this ECMO sub-bitular transplant, you need to understand that we're doing this to stabilize the patient. So before we list the patient, we need to normalize all the organ function, liver function, neurologically intact. Patient needs to have good kidney function. So very important is the concept that the time of listing on ECMO is when all the organs are working properly. Now, when do we move to an LVAD? How long do we wait? What is the data to support stopping the ECMO now moving to another? We don't have a lot of data, but what we know is that in general, especially in cardiogenic shock, longer support is associated with poorer outcomes. This is another recent paper showing the same concept in post-cardiotomy failure, that the longer the ECMO run, the higher the mortality, especially after 7 days. Again, very little data, but conceptually, today we can say that after 10 days, 14 days on ECMO, if we're not able to get that patient transplanted, eventually we should move to another device, unless the patient has a contraindication like RV failure or very small left ventricular cavity. In summary, for a heart transplant, I would like to say ECMO sub-bitular heart transplant is viable, although associated with higher mortality compared to no use of ECMO. Recent changes in donor heart allocation policy may increase its use as a bridge to heart transplant, so we need to keep our eyes open here. We don't know how things are going to evolve in this area. VA ECMO may be an acceptable option in patients that are not acceptable LVAD candidates in the absence of heart transplant contraindications. But there is an important lack of evidence to support the best strategy of support and timing. Very briefly, I'm going to talk about ECMO as a bridge to lung transplantation. As you know, the number of lung transplants has increased very rapidly. We're doing about 2,000 or 2,200 lung transplants every year in the US. Historically, more than 50,000 lung transplants have been reported at the ISHLT. Unfortunately, patients are getting sicker. More patients now in the ICU compared to 10 years ago. More patients on ECMO, 2% overall. About 10% of the patients go to transplant on ECMO in high-volume centers. As we have seen in other diseases, lung transplant use of ECMO has increased rapidly over the last few years. In general, we have used ECMO for patients that were on the ventilator, listed, waiting for transplant. But more recently, based on data that we're obtaining from different high-volume centers, we're actually considering patients on ECMO now before they get intubated. And we're going to discuss some of that data in a few minutes. We have different ways to support ECMO. In the veno-venous configuration, about 70% of the patients use veno-venous ECMO support, about 30% veno-arterial, mostly patients with severe, moderate to severe pulmonary hypertension. There are other hybrid configurations that we use occasionally when we have difficulties. CO2 removal systems, we're going to be discussing, I think, this in a few minutes, have been used, Hemolung or RAS, not approved in the US, approved in Europe. We have had the opportunity to use it with good results. The interventional lung assist that has been used mostly in Canada, Toronto has popularized this technique. We don't use it for reasons that we're going to discuss in 2 seconds. You can make the algorithm very complicated. This is from one of my good friends, Matt Baqueta, the different ways to do support. I try to make it simple. Patients that are hypoxemic with no pulmonary hypertension, VV ECMO. If patient is stable, dual lumen catheter. If it's not stable, standard VV ECMO, as we're going to see in 1 minute. If they have pulmonary hypertension, moderate to severe or severe RV dysfunction, we usually use VA ECMO in the different configurations depending on the patient. VV ECMO with ASD has been used. Outcomes have been very modest. They tend to close. I have personally had more stroke with this technique, so I abandoned personally this technique. The RAPA configuration with the Novalung, popularized by Toronto, not very used in the US. You need to change the pump very often because of the low flows. They tend to get a lot of thrombosis. This is the standard cannulation for lung transplant, dual cannulation. You can do it at the bedside, especially we use in very unstable patients. Again, this Avalon catheter came in 2010, published the first case by Bart Griffin and his group, and since then have been a rapid increase in the use. We're using about 30% of our VV ECMOs are now used with Avalon. The beauty of this cannula allows you mobilization. It requires a fluoroscopy. I started with a different technique with ultrasound in the abdomen, moved to fluoroscopy because it's probably safer. Mostly the 27 and 31 French are used in adults. Be careful that in small patients you can have SVC syndrome. If patients get sicker, sometimes the Avalon is not enough. You need to put a second cannula for drainage. And eventually, if they get sicker with RV dysfunction, you may need to convert this to what we call VVA ECMO, transform this to veno-arterial ECMO. When you put a second cannula, you get about a liter more in terms of flow. Femoral cannulation continues to be used again in patients with pulmonary hypertension. Again, always distal perfusion. We use NIRS monitoring continuously in our patients to prevent vascular complication. This will really change the prognosis of the patient. Axillary cannulation, as we did on cardiogenic shock, we try to use again with the concerns of bleeding. And we have also used this newer cannula, the Protect Duo, that goes in the IJ like the Avalon, but basically it's an RVAD. The tip is on the PA, and you can run the two sizes, the 31 and 29 French, and you can run up to 4.5 liters. We published the first case in the use as a bridge to lung transplant. We kept the patient for a month. And we have used it more. We're using this more in cardiogenic shock. We just submitted the first series with, I think, 30 cases of the use of this cannula as part of a database, a prospective database. So again, a good option also, especially in patients with pulmonary hypertension. This is the Novalung, the PA2LA configuration of pulmonary hypertension. Again, this is a pumpless oxygenator, and for that reason, the flows are around 2 to 3 liters, tend to have a lot of clot, and requiring multiple replacements, so we rarely use it, and most of the centers in the US have abandoned its use. Now, in terms of the data, since the first paper in 2010 showing that use of ECMO as a bridge to lung transplant was doable, a lot has, in 51 cases, was not great, as you see, compared to non-supported patients, but was doable. A lot of papers have come out. This was our first publication following that in 2010. In 17 cases, this was done in young patients, showing, again, good survival at 2 years. We were very impressed, and we continue that. This was when I was in Pittsburgh. Again, we had then 24 cases published between 2005 and 11, showing the same concept, again, mostly for cystic fibrosis and pulmonary and IPF. And more recent analysis, we were there, 48 cases. We expanded this to other diagnoses, scleroderma, COPD, primary pulmonary hypertension, and redo lung transplant. Most of the time now we were using this 70% VV ECMO, 25% of this group with the dual lumen catheter. The time of ECMO support was about 10 days. We learned that patients had more primary graft dysfunction compared to the non-supported patients that were longer on the ventilator, more tracheostomy, more ICU stay, but at the end, the outcomes were comparable. This was our experience, and we have seen the same now with 30 patients now at Penn. So this number continues to increase. There have been a number of publications. Here was our publication 2010, a number of publications, more than 600 cases now in the US since 2010. Again, with survival that go anywhere from 60% to 100%, depending on the series. This is our more recent experience at Penn. Again, very similar outcomes, 4 mortalities of 30 patients at follow-up. We have also used the Hemolung, as I did one case in Pittsburgh with a group there with very good results. The problem what we're seeing now is that these patients are staying longer on ECMO. So we have a number of patients now that are being supported for months. Some of these patients with ARDS or lung injury, as this case that had a bleomycin-induced lung injury. And they come to us supported for 2 months, and now we need to consider for transplant. So this is something that we're going to continue to see, and we don't have a good really understanding on how long we need to wait to get the lung recovered, or when do we need to get these patients transplanted. Patients are doing well, although. Now, not everybody has had the same experience. You know, this is a group from Italy showing that ECMO was associated with significantly higher mortality in 1 year. Patients were more on dialysis. They had more critical illness myopathy. So evidently there is a difference between our experience in the US in some busy centers versus some European centers, probably because they need to wait longer for a lung. The Milano group published the mortality increase after 15 days of VV ECMO support with close to 50% mortality in 1 year. But something that we have learned, and this is a series from Duke, that the importance of getting these patients extubated and mobilized. This is the mortality or survival of patients supported on ECMO on mechanical ventilation versus on ECMO alone. And ECMO alone is very similar to mechanical ventilation alone, but when you combine both, the survival at 1 year mortality was close to 50%. So it's important to try to get these patients extubated. This is also being confirmed, the rehabilitation concept on VV ECMO. This is a study from Duke showing 5 patients with shorter ICU stays, shorter ventilation, mechanical ventilation for transplant, less post-transplant myopathy when you get them extubated, sitting on the bed and mobilizing. So important concept, but there are many questions that we have not answered. Which patient will benefit? The duration, what is the duration that is acceptable for transplant? How do we minimize the complications? This is an open field still, and we're still learning a lot. Future systems, the Novalung now was paired with a small pump called the Delta Stream. They actually have some degree of pulsatility on the pump that may bring some benefit. We don't have it available here in the US. The Hemolung, the RAS, Respiratory Assist System, developed in Pittsburgh, is also a great technique or device to remove CO2. There is a Ventavoid trial that is ongoing. I think we're getting close to be enrolling patients now with COPD. They decided not to go into the lung transplant world yet, but it's being utilized and with success. This is some other devices that are being designed and some preclinical studies in Pittsburgh and also in Maryland by Dr. Griffith. This is our case with the use of Hemolung, 2 weeks on Hemolung as a bridge to redo lung transplant. Patient did great. And as a summary, I would like to say that ECMO is increasingly used to support patients with irreversible pulmonary failure as a bridge to lung transplant. The survival of lung transplant recipients supported with preoperative ECMO is comparable to non-supported patients in a mid to high volume center. Although VV ECMO is mostly utilized, there are other strategies that we need to be open to use central VA ECMO and other strategies that would keep our patients stable for a couple of weeks before the transplant. There is growing evidence that VV or VA ECMO and its modification to allow mobilization in awake non-ventilated patients may be associated with improved outcomes and hospital costs. And I would like to thank you all, but remind you that ECMO, as mentioned by the previous speaker, is a team effort. We can really not do this without the physical therapists, the perfusionists that are there, the nurses that are trained. So I think that the more we talk about it, the more we share our experience, the more we're going to be able to continue to improve the outcome of this patient population. I would like to finish inviting you to our meeting next month in Philadelphia for those that want to enjoy cold weather. But I would like to thank you again for this fantastic meeting. Thank you.